Okay. We shall start. Good evening, everybody. Good evening, PNAA. Good evening, guests. My name is Amelia Guzman, Education Chair of PNAA. Thank you for joining us in this fourth and last session of a four-part series related to COVID-19 pandemic. This series is offered free of charge by PNAA and PNAA Foundation and is dedicated to all nurses in this year of the nurse and the midwife. It is also dedicated to honor our fallen heroes of the healthcare professions here in the US and in our homeland. For those who registered and had connectivity issues with sessions 1, 2, and 3, go to the YouTube link found at the very top of the COVID-19 flyer and watch the recording. Then proceed to your PNAA support email to complete the evaluation and print certificate. This session awards 1.5 contact hours. You must be registered at mypna.org with a valid email address and must complete the evaluation to receive your contact hours. If you registered with a valid email address, you'll get an email with the heading PNAA support. This allows you to access digital and the evaluation form. You have 15 days from the last session, which is today. Evaluations will close permanently on June 21, 2020. We will not entertain any late requests. Our provider of contact hours is the California Board of Nursing. The Philippine Nurse Association of America Foundation is an approved provider of continuing education by the California Board of Registered Nursing, CEP number 14134. The speakers have disclosed no conflict of interest. The purpose of this series is to discuss issues that relate to COVID-19. PNAA and the speakers are not able to comment on an individual's risk factors or medical issues. For medical and personal concerns, please contact your healthcare provider. For current updates, please check coronavirus.gov or your public health department. Zoom instructions. All participants will be muted for the entire session. Only the speaker, the education chair, and the chat monitors will have open microphones. All questions must be typed in the chat box at the bottom of your screen. It is best to use the speaker's view located on the top right of your screen, a square with 3 dots on top. The gallery view will show all participants. This session will be recorded. If you are using a laptop or a tablet, please identify yourself by changing the name by your picture. Before Dr. Pacquiao's talk, our President-elect Dr. Mary Joy Dia will be giving an update on COVID-19 task force. So we will proceed with her talk before Dula Pacquiao because of conflicts of schedules. And we thank Dr. Pacquiao for the courtesy of the rearrangement of schedule. Reminder, registration is now open for the PNAA 41st Annual National Convention and our very first virtual national convention. It is scheduled for July 2 to 5, 2020. Please check your email for the links in the programs. I also would like to remind everybody that PNAA election will close on June 14 at 11:59 Eastern Standard Time. If you have not voted, please do so. We only have 29% of our members who have voted. There's a lot more to go. If you need your voice heard, please vote. So now I turn it over to Dr. Mary Joy Dia, who will give an update on COVID-19 task force. Mary Joy, take it away.
Thank you so much. Good evening, everyone. I am so glad that Dr. Dula Pacquiao graciously allowed me to switch the schedule so I could go ahead and share the latest updates regarding our COVID-19 task force. And I apologize if some of you have already seen this, and I hopefully that it would confirm and I guess validate the information that we have shared in the past. But for those who are first viewing this, we hope that we can share what we have done for the past 3 months that the COVID-19 pandemic crisis have happened. So during the time when it was conceived, It was really during the height of the pandemic. As you know, our very own President Madeline Yu have started this initiative even way back in early March. And it really overwhelmed a lot of our healthcare systems. PPEs has become scarce at the time, and consequently our members and also our dear president have been affected by it. And again, Madeline, we are very grateful for your support, and at the same time we agree with you with the loss of Manong Ami. So we really mourn all these senseless deaths, our nursing colleagues, our family members, and other healthcare professionals. So the task force was really formed to assess the impact and to initiate a fundraising campaign to support critical, intermediate, and long-term interventions and programs that will really address the community and the overall healthcare delivery for the long haul. So what we did is really gathered our regional vice presidents and also our Ways and Means Committee, our national secretary, as well as our PNAA Foundation president, together with 2 advisory councils to help us understand how can we move this forward at a national level, knowing that this is affecting all our 55 chapters all across America. And our goal was really to collect and summarize information from our members who were affected by the pandemic and really identify what are the anecdotal stories from an organizational perspective, what are the challenges that our members have encountered from the 4 regions of PNAA, and how can we evaluate the impact and help them along. So out of that objectives, we were able to understand that there are a lot of psychological impacts. And I know that stories will continue, and we have heard so many stories from our frontline. In fact, today, there was a webinar series that was sponsored by our PNA New York local chapter in collaboration with other community organizations. And what struck me from that conversation was that the psychological and mental well-being is real. One story that the participant shared was that she can hear the noise even in her sleep, and she has to resort in taking Benadryl. And I know that as Filipinos, sometimes we put it on ourselves and don't talk about it, but this is really the goal of the task force. What were the stories that were experienced with our nurses? What are the trauma that we experienced dealing with loss? Because we didn't have time to grieve at all. We were called to duty as frontline workers, and we didn't have time to really share those grief experiences with our loved ones. And how can we provide educational programs that will support our nurses, coach them, so this way they could really do some mindfulness exercises and then have a resilience in themselves. So we were focusing on those long-term goals. At the same time, we wanted to, at the time, really have priorities. What are the things that we need to prioritize for the first 3 months that we were undergoing this crisis? So by listening and advocating for PPEs and through our Must Our Nurses Drive campaign, and really supporting our local chapters. And I've seen a lot of the reports that were forwarded to us. And thank you, Madeline, for having that initiative in really providing weekly updates to our chapters. We were able to understand what are the things that they're doing locally in terms of mass donations, calling each other through texting, and also our legislative committee doing a letter writing campaign to the Congress. At the same time, we want to understand the intermediate initiatives that we could provide to our members. So this is where we're trying to understand how can we provide psychosocial support so we could express our sympathy and probably create a group support for everyone so we could prevent burnout and stress, and also at the same time provide educational awareness, and not only within our nursing professional but also outside of our community, and really make this culturally and linguistically applicable for our Filipino communities. We also wanted to increase public awareness on what's going on with the clinical trials, because this is a novel virus, and how do we prepare ourselves for the long haul, especially as the disaster will probably happen again in the future. So In that regard, we set up a fundraising campaign to support programs that will heal our nurses through the long haul, and also understand future programs that we could support for our nurses. As you can see here, I've taken pictures from different parts of our chapters. A lot of them really resorted to sewing masks as a donation. So I know that there was a lot of initiatives in that. Our nurses didn't have time to really take care of themselves, so a lot of donors have also provided meals and also channeling donations from local restaurants. And we also wanted to create a care package that really would feel the nurses that they are being cared for. And I understand other local chapters have done similar initiatives. So really, the intermediate goal right now is, how do we heal our nurses? What is our priority? How can we support them? And how do we create that narrative so we could share our story and really own it? When 2020 started, we wanted to celebrate it as a year of the nurse, as designated by the World Health Organization. But now we are left with trying to support ourselves emotionally. And this is where we brainstorm with each other. And we have worked with our communication and marketing and website committee in trying to illuminate these stories. And probably we could create a platform. So this way, we Filipino nurses share that story with the world. And another idea that came about is, how can we create a resilience program? So this way, it would be a long haul process, because as you know, we need to reflect first on what happened to us. How do we reach out to one another? And at the same time, really have that real conversations and really support each other. And then how do we recharge? Now that the pandemic seems to be flattening and the curve is flattening, there are still other social issues that surrounding us as a result of the violent death of George Floyd. All of these are compounding issues that's surrounding our community. So how do we build that resilience? How do we create that personal ecology that we could still continue to move on? And what are the research that could drive that process? So that's what we were aiming to do. And at the same time, look at it from a future of nurses directives, right? Because I am sure a lot of people are contemplating, is this the right job for me? Is this where I want to be 2 years from now, 5 years from now, especially for our young nurses? And I'm so glad that one of the participants that I listened to today is still encouraged to continue to become a nurse, because that's what she wanted to do. She said that she likes taking care of people, and being a nurse during the COVID-19 crisis confirms that vocation for her. So we want to explore that. And at the same time, maybe have a design session on how do we work with healthcare systems to redesign the supply chain distribution, because those are the underlying causes of where we are right now. How do we address the health equity and access, and really address global health? Because this is a pandemic that's affecting not only us here, but also our counterparts in the Philippines and other parts of the world. So our next step is really to have a governance and call to action. So that's what we did. We planned and executed. We did our Mask Our Nurses campaign. We had our programs, and we were planning to do the fundraising. And as part of that, as any other project, we will be monitoring what we have recommended to our PNAA Executive Board and also to our members on how to complete that, and what is the evaluation, what is the feedback of that, what are the metrics that we will do to measure that the task force recommendations are effective. So I'm happy to report back to you that as part of that process, we were able to work hand in hand with our Treasury and also with our Ways and Means Committee, with the support of PNAA Foundation, in trying to implement the Mask Our Nurses campaign. And coincidentally, when all of these are happening, and I don't know if it's God's providence that there is a pandemic crisis, and at the same time, May is a designated as our Nurses Week, but because of the World Health Organization designation of nurses as 2020 as the Year of the Nurses, we are celebrating this as a month-long celebration. So we were able to deliver to our members based on hotspot areas to prioritize the delivery of masks to our members. And this is just a testament of how our members felt valued after receiving that mask, because it is a way to show them that we are there even though we were not there with them in the front line. And we have great testimonies from our nurses. And thank you for that. Thank you for posting that in Facebook. At the same time, we are so lucky that our education chair, May Guzman, was very proactive in trying to come up with this COVID-19 series. We were able to facilitate that, and thank you for the help of our volunteers and our speakers who volunteered their time. We have frontline stories and reflections that our national secretary and our communications and marketing were able to collect and work collaboratively with our website chair to post this on our website. At the same time, our legislative committee were able to issue position statements for our COVID-19. At the same time, we work with our research committee through Dr. Sigrid Ladoris, Dr. Dadet Bloom, and Dr. Emerson Ia in trying to understand how can we use research to address the mental well-being of our nurses. And luckily, they were able to work hard through the perseverance of Danet and Emerson. We were able to submit a grant proposal to PCORI, and we hope that we will be able to get that grant. So let's pray for that. At the same time, I'm so grateful for our collaboration with the Asian Pacific Islander American Health Forum and through the collaboration with PNAA Foundation. Hopefully, we'll be able to work on a CDC grant that would help us disseminate information on how to do infection prevention and control in our community. So more to come on that as we understand the details of this project. So how can we help our nurses now and for the long haul? Obviously, this is not going to be a short-term process. This will stay with us for a long time as the cure for the virus is not yet certain. We don't have a definite vaccine yet, and we want to anticipate that we would need to support our nurses, and together we can do this. We are going to have a fundraising goal, and we understand the economic crisis that's happening all around us, but I'm sure that with the generosity of sponsors outside of PNAA, that we could really reach these fundraising goals to support our educational programs at the same time. So we have worked with our PNAA Foundation. They have updated their website so we could link together and start that campaign. We are grateful for the Filipino community from Google who were able to collaborate with us, and we enrolled in Inequities so that way they could promote our campaign projects in Google. Our Ways and Means Committee, through the leadership of Dr. Lorna Imperial, is also working hard to get external sponsors, so this way we could support our programs. Another way for us is just to be creative, and the upcoming campaign is really to utilize our energy to facilitate fun and at the same time have fellowship together, because I think that's where we are right now in just trying to support each other. So I hope that you would continue to stay engaged. We have our virtual PNAA National Convention happening in July, and we hope that you will be able to join us and be with us in this journey. And together, I know we can do it, and we will make PNAA stronger together. Thank you so much.
Thank you, MJ. Okay. Thank you very much.
Thank you.
I hope our members listened, and I hope they understand the whole effort behind this Heal Our Nurses program. And Madeline and MJ are going to the Kentucky induction tonight, so that's why we had them go first. Let's see. We are now for the main event. We are here to welcome our very own, our very dear Dr. Dula Pacquiao. She will speak about the social inequities in COVID-19 pandemic. Dr. Pacquiao is no stranger to us. Her degrees are EDD, RN, CTN-A, and TNS. And she's a lecturer at the University of Hawaii, Hilo, and visiting professor at UP College of Nursing, Professor Emeritus, Rutgers State University of New Jersey, and a consultant for Transcultural Education Research and Practice, Transcultural Nursing Scholar, Fellow, New York Academy of Medicine. Dr. Pacquiao is one of PNAA's icons, and we are very fortunate to have her speak this evening. She's a sought-after expert on social determinants. Let's give a very warm welcome to Dr. Dula Pacquiao.
Good evening, everyone. I'm happy to be here tonight. Although we are in the middle of pandemic, this idea of Zoom meetings perhaps has reached as many people that you may not really have reached otherwise. So let's take advantage of the Zoom meetings. So this is a topic closest to my heart. As you know, I just published the book on social pathways to health vulnerability that really speaks on the social determinants of health. I have three objectives this evening: to describe the patterns of social inequities underlying the experiences of individuals and populations with COVID-19, compare evidence of social inequities within the US and globally, and to discuss potential approaches to minimize the current social inequities. So the first few slides really talk about how different populations are affected by the pandemic. So one is the publication by Ebony et al. About the Blacks in Louisiana. And what they found in their study, that Black race, increasing age, higher comorbidity, having public insurance, whether Medicare or Medicaid, residents in low-income area, and obesity increase the odds of hospital admission. In this study, it said that 76.9% of Blacks comprised the total number of COVID cases in one county. So it's close to 80%. Black patients had higher prevalence of obesity, diabetes, hypertension, and chronic disease, kidney disease, than white patients. And the clinical presentation and admission for Blacks reflect their longer wait to access care. Now in New York City, even though Manhattan has more people, the Bronx has more cases per capita. Now we know that the Bronx has a lot of population of poor Blacks. In Illinois, this is more recently, Latinos have the largest portion of confirmed cases of COVID-19. And the indigenous groups, the Navajos in Arizona, Utah, and New Mexico, have the highest per capita than any state in the US. And there's also new publication about the possibility of decimating the Amazon tribes in Brazil if the COVID-19 would attack those tribes. Infected 11% of healthcare workers, and I saw this recently, 600. I don't know what those numbers are, healthcare workers, how they're broken down, I'm not sure. But nearly 50% of these health workers are Blacks and Latina females, earning less than $15 per hour. So you're looking at low status, low occupational status, and low income. There's higher risk for the incarcerated. Look at the picture here. The US has the most numbers of persons in prison. In 2017, there's a total of 2.2 million. And most of them are racial minorities who were unstably housed and with substance use disorders or mental illness. 50% have at least one chronic disease, with 81,600 over the age of 60. If you want to get HIV, go to prison. It's no wonder that most Blacks, although Blacks only make 20% of the US population, they make up 50% of the incarcerated population. And among these populations, of course, there's high prevalence of HIV, TB, and hepatitis C. It's no wonder they would have higher vulnerability to COVID-19. And we know with the Black Lives Matter that racial minorities do have higher arrest and incarceration rates. They made comparison that if you're Black, for the same kind of crime versus whites, you are likely to have longer prison terms and very, very bad punishment. So the morbidity also affects essential workers. And of the essential workers I want to focus are your farm workers and seasonal workers. Do you know there's 2.4 million farm workers in the US, 1 million of whom are unauthorized? And in New Jersey, there's 475,000 unlawful immigrants, and get this, who paid $11.7 billion in state taxes in 2017. Many of these people, though they pay taxes, they do not get any benefits from the government. They are excluded from those benefits. So it is totally wrong to say that they are a burden totally, because they do. A lot of them do pay. This is just New Jersey alone, 11.7 billion. And there's no provision for hazard pay, sick leave, or even hospitalization. They're working without adequate protection. And the White House has, in fact, used the COVID pandemic to really tighten down on immigration. In fact, there's a report that 900 migrant children and teens were deported without the opportunity to speak to a social worker or plead for asylum from the violence in their home countries. And Trump has used, in fact, the pandemic to truly deport people right away without any sort of recourse. And there's very little that we know about the homeless, because it's very difficult to get statistics on the homeless. But I would think that they will be one of the highest of those that are vulnerable to the pandemic. Now, in terms of mortality, it's no surprise, right? In Louisiana, this is one of the studies that came across, 76.9% of the patients who were hospitalized and 70.6% of those who died were Blacks, whereas Blacks only comprised 31% of that health population studied. In May, African Americans, who make up just 30% of the Chicago population, comprised about half of its more than 1,000 coronavirus deaths. In New York City, the Bronx had more per capita deaths than Manhattan, that has more population. 10% of fatality rate for people in their 60s with diabetes, 20% more than those under 50 without a high-risk chronic condition. So these were just evidences that I'd like to go over, and we will go into the explanation later on. So what's the impact of the pandemic? You know, the pandemic truly tells you that when there is illness, catastrophic illness, boy, everything goes haywire. Life goes standstill in a pandemic. This is how important health is. So if we look at the unemployment, now, of course, the White House said yesterday that there were 2.3 million jobs added as of May. But until I see more figures, I'd like to quote the previous ones. 40 million filed for unemployment benefits. 40 million out of about 331 million total population in the US. Unemployment has been predicted as high as 20%, but because of the May figures, they said it's about 15% and above. 40% of those affected earn less than $40,000 annually, and these were mostly women in service sectors. This is according to the Fed chairman, Jerome Powell. Black unemployment rate is at 16.7% last April, 3 times the rate in February and the highest since early 2010. Hispanic workers' jobless rate at 18.9%, up from 4.4% 2 months earlier. And these are caused by either illness, job furloughs, job loss, permanent job loss, or inability to get help for children. When your children stay home and you really can't go to work, there's nobody that would look after them. So poverty is a consequence of the pandemic. But before the pandemic, just remember this, the US, and we tout this as the greatest economy in the world, compared to the UK, we had 5.3%, equivalent to 17.3 million in deep poverty, compared to 15%, or 9.7 million of the UK population in absolute poverty. So I defined, I took the definitions for both because these are very different measures of poverty. Absolute poverty is universal. It's based on guidelines that has no reference to other people's incomes or access to goods. And most people in Europe probably would use this because they have universal insurance, they have support for education for most of their people. Extreme or deep poverty, this is what we have, 17.3 million in deep poverty, is defined as a state in which a person lacks access to all or several of the goods needed for meeting these basic needs. The World Bank defines it as living on $1.90 per day. That's pretty low. Tens of millions fall from middle class into poverty. Sometimes it takes a catastrophe to see that you are not very different from other poor people. This is how Obamacare, I think, passed last time, when so many middle class lost their income and their jobs. So when you can see the leveling effect of the pandemic, it gives you a little bit of compassion and understanding of what it's like to be poor. We know about food shortages because of the transportation as well as the production disruption. So they create higher food costs, making it more difficult for people, and food insecurity. In fact, they said that the USDA school breakfast and lunch program and the child and adult care food program that serve nearly 35 million children daily were affected or disrupted. And think of poor families that have provide extra food for their children. When you have nothing to do and you stay home, the more you eat, right? Food is a show of love and security. Just imagine having children starving in your household. 1 in 5 children do not have enough to eat, according to the Brookings Institute. And most people have inability to pay housing, their mortgages, and some have become homeless. Inability to pay for medicines, in fact, foregoing any medications they need and other health supplies. So poverty impacts not only the food, the housing, but also our health. So what about healthcare access? Now, if you are poor and you are in a poorly resourced environment, your hospitals are not likely to be well resourced either. So if you think of Jacobi Hospital and University Hospital in New Jersey, These are public hospitals. Think of PGH in the Philippines. They have to take everybody, and they are the most poorly funded. My friend in Aklan says to me that all the people that went to Makati Medical Center went home well. Well, I said, yeah, but guess who are the people who go to Makati Medical in the first place? Compare that with people going to PGH. So lack of ICU beds, ventilators, qualified personnel to run these ventilators. Due to shift to outpatient care, we have really reduced inpatient beds for many years, pushing really much of the care in the outpatient department. So when the pandemic occurred, it just made it worse because we did not have enough of these resources and personnel. Hospitals in low resource settings are overwhelmed because of lack of resources and personnel. And if you look at the breakdown perhaps of healthcare workers that came down with the disease, it's very possible that many of them came down from these facilities that were not prepared. Look at the pandemic affecting nursing homes. They were not prepared for the COVID-19. It's no wonder they are severely affected. Unemployment results in loss of medical insurance and lack of universal access to testing and treatment. In fact, it's only now that we're seeing the disparities in the number of cases and deaths that the government suddenly are understanding or realizing that we now have to put more testing in areas of the poor, where you will have likely transmission of these diseases. So now this is the topic that I have. So I'll spend a little bit of time on this. What are social determinants of health? They've been published several times. If you go around the world, it is not really a wonder that poor people, those with low education, living in low resource environments, are the most affected. It is no surprise when you see morbidity and mortality rates affecting or impacting differentially different categories of populations. It's because of social determinants of health. And what are they? These are the social, economic, and physical environment in which a person lives that influence their overall health and well-being. In other words, it's really your place. Your place in society is affected by the environment in which you live. Environment takes two components, the social, and that includes economic and your political clout, and the physical environment itself. They all combine to form the environment, and your place affects your health. So what do we mean by place? Place is affected by your socioeconomic status, by your race, especially in the US. Race is a significant social determinant of health. It is affected by history of discrimination and exclusion. Look at the indigenous populations such as the Native American Indians and the history of slavery affecting the Blacks to this day. So in other words, you are who you are, and you are because of where you live. Discrimination and exclusion impact the future of people, where they live, what kinds of jobs and opportunities they have, and what kinds of resources are available in their environment. So it stems from historical, structural, and infrastructural forces. Let's just give an example here. Sir Michael Marmot, who is an epidemiologist from England, studied about 30,000 populations in the UK. They were all white. And remember, the UK has universal access to healthcare. But what he found was the social status syndrome. There is a health gradient, he said. The higher you are in the status hierarchy, you are likely to have better health. And those people below in the status hierarchy is like a step ladder. Your health is worse off than the person above you. And so he actually found that indicators such as high cholesterol, smoking, that these had, and obesity had very little impact compared to the social place or status of the people he studied. Powerful study. He followed them for 30 years, 3 decades. This is really the reason why we are into social determinants of health, because of Marmot, who became the first commissioner of social determinants of health in WHO. So what are examples of social determinants of health? We have socioeconomic status, income, education, occupation. Those are the 3 measures of socioeconomic status. When you're poor, you're likely to be in an environment with no quality of education. Therefore, you are not likely to go to college. And for that reason alone, you are likely to have very low paying occupation with very or no health benefits. Discrimination. Discrimination. Do you know that studies have shown when Blacks enter a community, there is usually white flight and disinvestment in the environment. And it's no wonder that poverty and race they are concentrated together. Being Black and poor in that environment, boy, you are so disadvantaged all your life. There's accumulation of disadvantages that pile up. The same way if you're Native American and they put you in reservation camps. There are no schools, you have very little access to grocery stores, very little access to paved roads, and what? Very long distance access to health facilities. Your life really is so worse off. Experience with early adversity, and this goes on. It becomes a cycle in the family, because the younger you are and the earlier you experience adversity, your life is already cut off by a lot of years. Living in high-risk, toxic, and deprived environments. You will carry a gun if you live in very high-crime areas, wouldn't you? And you're likely to smoke pot when there's a lot of them available where you live. Anyhow, studies of Yakima Indian children in Washington found that the children exposed to inorganic farming actually had neurological deficits and cognitive deficits that were permanent. Think of lead toxicity and those kids in Flint, Michigan. Already their life is predetermined early on. So this is what Krieger calls humans embody their ecologies. That's a beautiful phrase. Human embodiment of ecologies. Because ecology has a physical component and a social component. And the process of embodiment is facilitated by prolonged stress experienced by the people, causing dysregulation of body systems. Just think of cortisol, adrenaline, norepinephrine, and all those factors that come, as well as the cytokines, right? So it's no wonder you have obesity, hypertension, cardiovascular disease, immunosuppression, insomnia, PTSD, substance abuse, mental illness. In fact, at the cellular level, they find that prolonged stressful experience of poverty causes a decrease in the length of the telomere of the cell. Telomere actually defines or predicts the longevity of the cell. The shorter it is, the shorter is the span of life. So already they are at a disadvantage. And if we only treat them when they come to the hospital, we are too late. So all this hullabaloo about whether we should redistribute ventilators and whatever medications that are being experimented to involve people that are so disadvantaged, I would say it's too much fuss that is too late. Too much fuss that is too late. When you're dealing with life and death in a hospital, I don't think it's hard to really think of, I should focus more on the socially disadvantaged when all of the people you see are really crying for help me. I'm dying here. So I think the measures that need to address social determinants should occur prior to hospitalization. Allostatic load is the effect of prolonged stress experience. This was coined by McEwen. And what they found biologically, this is why many of the MDs and all the biological scientists are now understanding, yes, social class get into your body, discrimination get into your body before we take them as a part from what we do. We always think of the genes, the microbes, and all of that. Well, guess what? Your own body systems that protect you from stress, flight, or fight response, if that is prolonged, actually they cause dysregulation of your body systems, and they create pathologies that shorten your life and increase your suffering. All right, so now I will go into capitalism and neoliberalism. You know, they use the word liberal really for whatever. They think it's Democrats. Please don't think that way, all right? Capitalism is the idea that when we have money, we put it further to increase our capital or profits. Profits before life. I mean, look at the reopening after the pandemic. And people are really divided into this. We should go for the money. And literally people are suffering, so they need to reopen their business. Neoliberalism, on the other hand, says that we firmly believe in America in the idea of individualism, that it is your responsibility to provide for your own health care, for the education of your children. But when you're thinking of vulnerable people, that responsibility may not be a truism. And there's always more people than rich people in any country. In fact, the philosopher Voltaire said, there is the abundance of the rich because of the preponderance of the poor. Look at what we're paying, how much we're paying now for food because of shortages, because the essential workers that are making very low wages are not there to gather or harvest the foods that are brought to the supermarkets. But anyway, the emphasis on economic profits over quality of life and survival issues. And the idea that health is a commodity that can be traded, you can make money out of health. Think of the race to make the vaccine. Do you know why this is such a race? Because it is a pandemic that affects wealthy countries. There is money to be made. Malaria has ravaged Africa for years and years. And there's nobody looking at vaccines against malaria, not even Ebola. But boy, if it hits our wealthy countries, you will be sure the pharma companies will be in a race to make that much money. So capitalism also degrades the environment because the pursuit of economic profits is always a priority prior to quality of life issues. And we're now suffering from catastrophes, pandemics that we've never heard before. Think of how much we have commodified wild animals to supply our need for meat and need to make money for whatever meat we can get. That is what capitalism is all about. And the idea of neoliberalism is, I don't have to worry about you. I only have to worry about myself. You have to be responsible for your own instead of me looking in a more ethical, moral fabric so that what I do has impact on many other people. Anyway, but this is America, the hotbed of capitalism and neoliberalism. That's why we're still talking about universal health care. Public health policies and vulnerable population, this is what we need to think. When you understand social determinants, you will see right away how public health policies in relation to the pandemic will not work for a vulnerable population unless you do something. For example, shelter in place. Think of Native Hawaiians, the indigenous populations, and those poor people, they live in one room. 3 generations of Native Americans, the Navajos, they live in one house with very small partitions or maybe a few rooms. What about the homeless? Look at this picture here. What about the incarcerated? So unless we provide for spaces for these people where to go, shelter in place is only for the people who have the means. The same way with social distancing. The employers have to provide for those essential workers. If I work in the meat processing and you make me responsible for my testing as well as for my own garb, I don't have much of that wealth or economic wherewithal to provide for that. So they should be set up so that we impose on certain people who can afford it, as well as those employers who should be able to take care of their employees. Hand washing, I mean, simple as hand washing. Do you know that 30% of the native Navajos do not have running water? They pay a lot of money for water because the water that they have is polluted by nuclear wastes. You would not think this happens in America, do you? Well, think again. So that unless you can provide for access to that water to be able to rather translate this hand washing, it's not going to work. School closure. School closure without any form of accommodation for the vulnerable creates greater disparities. I'd be lucky if my parents are well off and they are well educated. And we have access to computers and the internet. But for others, this is really a penalty. It increases more of the disparities. Telemedicine requires literacy. It may not work with certain vulnerable populations. So think of how we will be able to implement many of this. And rationing of care, I mean, there's a lot of ethics issues that have come about because of the COVID pandemic. But when you are in the hospital, as I said, I would not fault you for not thinking too much of social determinants because the needs of everybody is life or death. And to me, it's like too much fuss, as I said to you, too late, too much fuss and too late. It should have been done earlier prior to them going to the hospital. All right, so what are the lessons learned? Disaster preparedness. Disaster preparedness means focus on the most vulnerable with the highest of risk. They are the ones that are likely to be most affected. So if you're looking at testing and access, go into those areas that need it the most because they are likely not going to access them. And think of people without health insurance. What do we do in order to get them to go for testing? And invest in elimination of social determinants of poor health way before. This has to do with public policies, governmental regulations. They should really occur prior to that. For example, zoning. Why do we concentrate poor people in one area? Why do we put all toxic sites in one area? Do you know that Newark, New Jersey, with predominance of Black Americans, they sit on 10 polluted sites, land sites that were identified by the federal government as needing cleaning. Why do we have 10 there and nothing in other areas? Why do we have to concentrate them in certain areas? Most poor people buy into these areas because that's the only one that's affordable. Why do we put all the airports, the harbor, the port of Newark, the airport in the same area? Do you know that you get high pollution from idling ships and the traffic in Newark airport? Every minute there's a plane that takes off or lands. And during disaster, provide safety net to mitigate stress. When we provide incentives, the government usually, this is the neoliberalist idea, fund the corporations first, hoping that they will keep their employees until October, supposedly. But has that happened? They always think of their profits first. I think the idea is give the money to the people first so that they're not desperate. And those that can afford it, you know, when you have accumulated wealth, you'll have more time to kill. You will not be so desperate if you have more money saved. But for those people living from paycheck to paycheck, get them to get the money first and get them enough money to live on. But you know, some Republicans were saying, for example, that they are afraid that if they give more help, that they are not likely to go back to work. Well, probably one of the reasons is, I don't want to go back to work if I'm exposed to COVID. Why shouldn't I be given that choice just because I'm an essential worker? It should be the same for everybody. Otherwise, you have to pay for protection. Social reforms that we need. I don't see why two people working in the same household, or at least one adult working, they are still in poverty. Do you know that most people on welfare, they have one adult working full-time and even probably extra jobs in between, but they still can't make it? It's about time we do what most European countries do. Look at wages, make it livable. Universal access to healthcare. I don't know why we're still arguing about this. Of course, there's an infusion of money in the beginning, but in the long run, it saves you more because you know why? There is only one payer system that could negotiate with all vendors. We have too many vendors in our healthcare. We have too many insurance systems. That alone costs us what? $61 billion or more, probably in the hundreds of billions of dollars now. Safety net during illness and unemployment. It is sad that when you're sick, you have nothing to eat, you could not access healthcare. It's so unfair. Access to affordable and free quality education. The pathway to better health when you are poor is to get better education. If it's not available in your neighborhood, it's going to be tougher for you and your children to get good education. And support for children and families. Children need supervision. Children need support and security at home. So that if both parents are working, we need to provide something, especially a safety net for those poor families. Otherwise, one has to go to work, the other has to stay home, and they don't have enough money to feed their children. So social justice, what is social justice? Justice really is fairness. But when we speak of social justice, it focuses on the society's obligation to protect the most vulnerable. According to the name Rawls, John Rawls, the theorist on justice. He says society is just when it protects the most vulnerable, when the most vulnerable is rendered less vulnerable. So fair taxes and tax incentives. Usually we always think of the rich in our taxation for some reason. And with the shifting of the state taxes to the federal, the more that we have really made it harder for states to have a cushion during pandemics. Timely and comprehensive support. Look at these incentives, the support that we're giving to people. To this day, many of them have not received them. Just imagine if you have nothing really. You only have $1.90 a day to live on. And we've been here since what? March. Redistribution of environmental risks that has to do with zoning, regulation. Fair housing. We cannot concentrate poverty and race at the same time. Studies have shown that communities in mixed income neighborhoods always fare better than those in purely poor neighborhoods. And protection of women and children. All right, so here's another one, global citizenship. How's my time? I'm almost there, right? I'm sorry. Global citizenship. We have to think that we are part of the world and not just into our local cocoon. This America First is anti-global citizenship. In order to have global citizenship, that our ethical, moral perspective must address the world, must address diversity, so that when we do advocacy, it's not only for us, but for everyone. When we do empowerment, we think that if we empower just ourselves, how would that affect the other people's empowerment? And if the poor and the vulnerable have the least empowerment and power, we need to mediate. Mediation would be seeking collaboration and networking, building social capital. Collaboration with politicians, maybe with activists, with other local communities. So vertical and horizontal collaboration, but we build community social capital. But in order to do that, we need to understand the root cause of poor health. So those people in nursing and medicine and health think social determinants more than just the anatomy and biology and pathology. They come later. So begin with a compassionate understanding of why people are sick in the first place or most affected, and develop empathy. So seeing what they are and experiencing perhaps in you, what they've experienced, that should stimulate empathy and compassion. Population-focused research in teaching and in education and research. Focus on not just groups of patients like cardiovascular patients. In population health, you focus on everyone in the community. Think of families. So nurses always say they think of patients as populations. Well, you know what? You're not addressing everybody. That's not population-focused health. You're addressing disease of certain individuals in the community, but not population in terms of health. And anchoring of organizations, many of us work in organizations. It's hard to have power alone. We need to use our organizations to be anchors of our health promotion for the community, engagement in community. All right, I'm running my last slide. Okay. So what lessons have we learned so far? Health, according to the WHO, is a human capacity. Why? Because health is enabling. It allows you to do and to reach your goals. Is wealth. Without health, you can't work. Look at the pandemic. Even if you want to work, you are in lockdown. Health is security, and health is social stability. When you combine the police brutality with the economic impact on the poor of the pandemic, it's no wonder we have massive rioting. So this is why we need to be health focused and not just on the pandemic. After the pandemic, we have a lot of work to do. We have realized what social determinants are in the pandemic. Don't stop there. We'll have to continue after the pandemic. Thank you. You can do your chat. Let me see if I can open that one. If you have any comments.
Dr. Pacquiao, this is Manny Ramos, one of the chat room monitors. There is a question that is asked. Do you think that the current uproar on racism will change our course in history?
You would hope that the massive participation, especially of non-Black population in this sort of protest, hopefully it will continue until we get regulations and certain reforms. And you see now in the House, in Congress, in the House of Representatives, they are beginning, as well as in many states, they're introducing legislation about police reforms. We've been asking for that for so long. Hopefully, it should start from that, but it's not just that, right? It's not that just that. It has to improve the education where they are, has to improve job opportunities. It has to improve police response. You know that the owner of ShopRite in Philadelphia that was looted so heavily, he was interviewed this morning, and what he said, I don't blame the local people. He said, what I am so disheartened, he says, because the police did not respond. We called them many times. The people in the shop that were supposedly guarding, they had to go up the roof, and he had to call the fire department to get them off there. So it needs much more than that. The police reform is one, but the economic, the education, these are many other things that need to happen, because in vulnerable populations, the risks are so very high and so many at the same time.
Thank you, Dr. Pacquiao. There's no other questions in the chat room.
Dr. Pacquiao, I have something in my head. When the lawmakers are trying to change and the bill is dead on arrival in the Senate, it seems like it's a hopeless effort. And you watch it again and again, you know, it seems to me that only an election would change the course of the changes you want to make. Would you comment on that?
Absolutely. You have to be an intelligent voter, and all of us has that right and an obligation. You cannot pass, for example, universal access. If you believe in that, you need to have both Senate and House to pass it. So you choose very carefully who you elect. Europe has universal insurance, and they are mildly capitalistic as well. How do they manage to balance this? Why do they have it and we don't? Why are we so allergic to that idea? So it is about time that you figure out the ideals of these politicians. Do not merge. You know, most Filipinos sometimes they think of abortion as the main issue, and abortion is everything. It's all or nothing. There are many other issues that are so important in life. Do not lump them into one party, especially for healthcare workers. We see it every day. We see evidence of social determinants of poor health. And yet, we seem to think that these issues are so different from the other issues that are affecting quality of life. You need to really pay more attention to this. I see this in my students very often because we are so narrowly focused on disease, and most of our work has to do with diseases. But unless you pay attention to how power is derived in this country and how you create social reforms, you better think twice about where your money is coming from.
Thank you very much. I wanted to drive that home very well because in your frustration of listening to the news and the things that has to happen in our society, it seems like you just get to a dead end. And the only thing that I see that's going to change things is the election. So I really needed to drive that home because that's my feeling and that's my thought. Thank you so much.
You're
Dr.
welcome.
Pacquiao,
Yes.
thank you so much for that wonderful presentation. You really articulated very well some of our thoughts and the conflicts that we feel about our role as healthcare providers, healthcare givers, and the ideologies that are not consistent with our role as a provider of care, specifically the neoliberalism and the capitalism ideologies that predominate our society. I would like to get your thoughts, you're the expert on this, with regard to immigration and immigration status as a social determinants of health, because it's becoming very clear now. Yes, for example, as an immigrant nurse, as immigrant nurses, we are on the other side with regard to socioeconomic status, but this current pandemic has really made it clear that being an immigrant nurse, being a frontliner, is a big determinant of mental health and well-being. So I'd like to hear your thoughts about that status, and immigrant status, and how it relates to social determinants of health.
Mm-hmm. The backlash on immigration is always attached to economics. You will see more negativism whenever there's economic distress in the country. But then on the other hand, you have really politicians with an ideology of anti-globalization or anti-immigration. But you know what? If you look at the fertility growth, you watch this one. If you watch the fertility growth in the wealthy countries, we will probably, except for the immigrant population, they would have been zero for many years. And then they will begin again to see that you cannot, it stagnates. It stagnates economy when you don't have an infusion of young generations and many generations. And who are the ones that are more fertile but immigrants? And it will come back as a political issue. Just think of right now, how many people looking at the epidemic and the effect on the health workers, except for the fact that nurses make money, it's hard to attract maybe young Americans to go into healthcare right now. I don't want to die. When they are in need, they will see that they will favor immigration again. So I like the idea that we showcase our contribution and the number of, there's 600 healthcare workers. Is that true? Nationally, is that the number nationally that died from COVID? And how many of them were Filipinos? I would like to see that, so that they understand that you are a huge part of this. Most Filipino nurses that I know, they love to be in ICU. They work in ICU. How many of them perished? So we have to see that these will impact eventually. Look at the food prices and the lack of people harvesting the food. Americans are practical in one sense, but they need to suffer and see what all this anti-immigration is doing to the economy in the long run. And it becomes a vicious cycle. When they're in need, remember when the H1 came about and when they had enough, they closed it and they wanted to send many of you home. But Philippine Nurses Association of America did a lot of things to keep us here. It will always be there, and many countries are the same. The same in England, the same in Europe. The anti-globalization is sweeping them because of the economic forces. But once the economy is better or they see the need in catastrophes, they will see that they need more of immigrants. I don't think you can live by America alone. We would not have mass shortages if we continued our negotiations with China. To this day, I could not buy masks except the cloth ones. And why is that? I don't know, but it's anti-business if you think of it.
Dr. Pacquiao, one of the participants asked if you could please comment on the efficacy of telehealth and/or telehealth as a platform for health access in relation to social determinants of health.
Okay. Now, telehealth will work, I think, for your middle Americans, middle class Americans, but for poor and especially your LEP, your language less proficient in English language population, you probably need to train community health workers. Around the world, especially in the third world, the work of community volunteers, very important in assisting the healthcare professionals who are able to reach the areas, especially in rural areas and in areas that are mountainous or very isolated areas. So I think it will only work if you have local help that you will train in terms of confidentiality, in terms of the language that we use. Because for many of these people, it's going to be very difficult really to understand and follow your instructions. In fact, I have one student who's an NP at Columbia Press, and she's doing this now, and most of her patients are in Harlem. And she says to me, it's very difficult. I said, why is it so difficult? And because she's dealing with diseases such as HIV. And she says, it's hard for me to tell the husband to get out of the room when he is there and I'm speaking to the wife and I can't share. I don't have the liberty of sharing the lab reports. So maybe there are some standard procedures that need to be agreed on so that families understand that when they pick up the phone with a care provider, this is like HIPAA provision. Are you alone in the room? And we can invite others with your consent. But in the meantime, this is what I'm going to ask you, and maybe you should decide whether or not your husband should be present. So these are some adjustments that we need to do. But telemedicine is good. There's a lot of pros and cons about it, and it doesn't need to be face-to-face. Anyone else?
Yeah, there's one more question, Dr. Pacquiao. Your time is up, but if you don't mind, we have one more. Do you mind? Okay. How do you propose we now incite, where is it now? How do you propose we now incite the underprivileged to be comfortable or fight to access health care when now it seems it is an unsafe environment?
Yeah, they're
It's
scared.
always been fought for, but how will this change due to the current pandemic?
Okay. Well, I'll tell you what. I worked for many years in Newark, and when I started at UMDNJ, the previous was taken over by Rutgers. We surveyed the community, and these were mostly Blacks. And I was astounded to hear from them that they do not want to go to UMDNJ unless they are deathly ill. They don't trust them, and they don't trust the healthcare facility. You know, Black people know that healthcare facilities in their own neighborhood are likely not to be good. You know that. You might be surprised. In fact, many of them would like to go to St. Mike's or Barnabas because care is better. And you know, there are studies that show that when there's predominantly white population accessing the hospital, there are more of those lab reports and lab tests that are being done. More treatments that are being offered than when they are in a predominantly Black neighborhood hospital. Okay, so that's one. Knowing that, that is the background in normal circumstances. And now they know that a lot of their people died going to that hospital in this pandemic. Truthfully, I don't even want to go to the hospital right now myself. When my doctor's clinic is in the hospital, I really dread to go into there because I think I might be exposed, or you don't know who's walking in there or whatever. But more so with Black people. These people who are poor and they know darn well that the hospital is not very well funded in the beginning. They are likely to be more fearful. So I think the idea would be, you might say that these are the things that we're doing now that can protect you, but maybe we should move out to the community. There are some telehealth, your FQHCs, your primary care centers. These are your mediators to ease maybe the fear of going to the hospital. I don't know if they still have it, but when I was there, we had the mobile unit that would go into the neighborhood. They would like to go into the mobile unit, but they don't want to go into the emergency room of the hospital. As much as possible, they hate going there. And you would think, you know, these are their people. If you go to UMDNJ, University Hospital has mostly Black people as staff, not just patients. But yeah, my friends who are Black would say to me, Black people now, if the hospital is in the Black neighborhood, it's likely to be no good. And you blame them? Likely to be true. If I can go to Makati Medical Center, why would I end up in PGH? Right? That's the last one I will go to. I hope I answered that. Tough question.
Yes. We're a little over our time, and we appreciate granting us a few more minutes, Dr. Pacquiao. As always, I'm your #1 fan. I always told you that. Forever grateful for your expertise, for your time, and you're always supportive of our efforts in the Education Committee. Dr. Pacquiao, thank you so much.
Thank you so much, everybody. Have a good weekend.
Yeah, I'd like to thank also the Education Committee that are present here now. Cherry Tino is here, Manny Ramos is here, Emerson A is here, and I don't know if Mindy Ofiana is here. They're your Education Committee, and we're always committed to giving you quality nursing education, continuing education programs. And of course, you probably know by now that we are now the holder of the gold standard. We are now the ANCC Provider Unit P0613. So thank you. And also, 2 reminders, our July National Convention is being held virtually, July 2 to 5. And you will check your email. The program and the links are all sent to you. Also, please vote. We only have 29% voters that casted their votes. Please vote. If you want to change something, if you want to have your voices heard, vote. Vote for PNAA, vote national, vote local, just vote. Thank you, everybody. Thank you so much. Thank you, Dr. Dula, forever in your debt.
Okay, bye.
Bye-bye.